Yeah, just give me the admin right now. So make me the admin
On Zoom or
host.
Facebook?
Yeah, no, no, on the Zoom part, just give me the host part.
If I make you the host, I won't be able to share this. So
Just
you
one
want to
second
try
before.
something, or what are you doing?
Yeah, yeah, I want to try something. Yeah.
Just a second. Huh?
Okay. Yeah, it's alright, yes.
Okay, now I'll make you the host. Yeah.
More things live on Facebook. Hmm.
It is some permission error from your end, either in Facebook.
Yeah, I don't know. Zoom, how I can change.
In Facebook settings, just see.
I tried. Am I the public only mean emotion? Yeah, it's happening now.
The meeting is being live streamed.
Yeah.
Okay, now are you getting the option? You removed the permission. So now check if it's
Ah,
only showing you timeline. Go back again. Stop sharing on Facebook.
1 second. I'll go to the Zoom. Uh, got it. Stop live stream, right?
Yeah.
Okay. Yeah, it's again giving me the option of going live on Facebook. It happened.
Yeah. So you go live on Facebook and see if it's only showing you timeline or it's also showing you share on groups.
Yeah, just I'll check that. No, it's just showing me the timeline.
Okay. So go on to your timeline and then let's see if you can share it from there.
Yeah, I'll just go live and again from my timeline, I'll
Yeah.
just check. Share, share to a group. Digital Dental Forum. Yeah. Yeah, I'm able to do that.
Yeah. So
Yeah.
keep it on only right now so that
Okay.
we can
So should
start.
I post on the Digital Dental Forum right now or later?
Share it on Digital Dental Forum. No?
Okay.
I can see Hemal Shah is live. So
Yeah, it has happened.
yeah, it's showing on Digital Dental Forum as well now.
Okay.
Yeah. So
Yeah.
I'll just reclaim host. I'll play that
Yeah.
PPT once, and then because there's only one person who's joined in, Dr. Teja, welcome. And then I'll give you the thing back on. Okay, Dr. Hemal, I think welcome to you and a very good evening to all you people who are watching us today. We are on the third leg of our Edtech series that we have launched. And I think what we shall do is I shall give you a brief introduction to introduce Dr. Hemal here. Dr. Hemal Shah has completed his BDS and MDS in prosthodontics from the D.Y. Patil School of Dentistry in Navi Mumbai. He's a university topper and a gold medalist in prosthodontics and was the proprietor at the Ceramil Dental Studio with 5 years of laboratory experience. He currently runs a firm called as the 3D Smiles to provide guided surgery solutions to other dentists. The past ITI study club director and a key opinion leader for Bredent implant systems. He's also the faculty with the IDA Mumbai head office and into private practice and consultation. So I hereby welcome Dr. Hemal Shah, who is today going to talk on anterior implant aesthetics from analog to the digital workflows. Thank you, and over to you, Hemal.
Yeah, hi. Hi, everyone. Thanks a lot for the kind words, sir. So, uh, can you see my screen right now?
No, you can start sharing your screen.
1 second.
Yes, now we can see it.
Yeah. Okay. So, talking about my journey for topic for today's discussion, it's about my journey from analog to digital in a way, how I have progressed over the years. So, I'm gonna share with you about say 11 cases or so today. And when we're talking about anterior aesthetic zones, I'll just give you a brief idea of what key factors I feel play an important role in choosing a particular case and moving ahead with that. So the goals of the lecture are going to be analog versus digital planning and the types of cases. If in between we want to discuss something, then we can just stop or maybe discuss, or you can write down some messages in the chat box. So the key points that we are going to discuss are the cross sections of the bone, how that's a very important factor in deciding maybe the timing of implant placement, the importance of provisional prosthesis, and reverse engineering in guided surgery. So coming to the SSC assessment, this is from the ITI world, so International Team for Implantology. They have come up with a straightforward, advanced, or complex assessment for any particular case. So S stands for forward, advanced, and a complex case. Now there are key factors or the risk factors that they say where a case can be determined to be either a straightforward case or an advanced or a complex case. Now, these are some of the risk factors that we are looking at. Some of the high risk factors are very thin biotype of the tissue, triangular shape versus an oval shape. An oval shape is easier to replace versus a triangular shape of a tooth. A very high gummy smile is always going to be a high risk factor. So, depending on the factors, we can judge a case to be a straightforward case, advanced case, or a complex case. If the buccal bone is present or an absent or it's absent, so depending on that, you can categorize that particular case. Timing of implant placement is very important or very crucial when we are planning for anterior aesthetic cases, because whenever possible, I would always try and go for immediate implant placement. If not, and if we are going for a delayed or at least an early implant placement, which is 1.5 months from the time of extraction, should be the goal. Because if we are looking at grafting any particular case, we are looking at 4 to 6 months of undisturbed site. After that, again, implant placement, again, 4 to 6 months of time till you finish the case. So almost a year goes by. But if you are doing the case in, placement immediately, we are looking at a time frame of almost 5 to 6 months to finish a particular case. So timing of implant placement is very important in such cases. Loading protocol, if we can have a very good primary stability and the occlusion permits, we can load, we should always load these cases immediately. If not, then a delayed loading or conventional loading is preferable for anterior cases. Now, all the anterior cases are divided into three types of defect: type 1, type 2, and type 3. Type 1 defect, when you have the buccal bone and the soft tissue is intact. There is no loss of buccal bone or there is no loss of soft tissue. Type 2 defect, there is loss of the buccal bone and the soft tissue is intact. But in a type 3 defect, we are losing both the hard and soft tissue buccally. So these are the three types of defects. As I was telling you about the cross section of the implants, so cross section of the bone being very important for placement of implant. These are one of the classifications where they have categorized according to the percentage how many population have that particular cross section. Now this cross section helps us determine how your implant angulation is going to come, where you can get the maximum primary stability if you want to go and for immediate placement, and depending on that the prosthetic angulation correction that you need to do. So studying the cross sections become very important whenever we are doing anterior implant cases. This is another classification showing different types of cross sections of the bone in the anterior aesthetic zone. So 3D placement of the implant positioning is very important, where the neck of the implant should be at least 3 millimeters below the CEJ of the adjacent teeth. It should lie within the contour of the buccal bone and minimum distance of 1.5 millimeter from the adjacent teeth. So three-dimensionally, there should be good bone all around. Now let's move on to cases. We are going to discuss about 11 cases, and I'm going to go in, try and show you my experience, what I was doing or what I have changed right now, or things that I've had done earlier and I would not do again. So it's going to be a journey, and that's what this topic is about. It's a journey from the analog to the digital part. So this was a case of a fractured central incisor to one. Endo treatment had already been done. The post was removed. The tooth had some fracture lines in it. And in this case, there was generalized recession type 1 defect, if I may say, because there's generalized recession. The buccal bone is intact overall as compared to the adjacent teeth. Now, the incision design is key in such cases, where you can see over here, we have, since a case of diastema, I am giving a papilla sparing incision over here, going beyond the mucogingival junction and giving a horizontal incision to increase the length increase the pull of the tissue. So once the tooth is extracted, uh, the most important part in anterior cases is to determine where your first drill should be. The point of access of the first drill is very important. So just measuring the length of the extracted tooth, using a prosthetic template so that the three-dimensional implant placement is correct. Uh, Positioning the first drill, as I was saying, is the most important part. We are not at the apex, we are at the palatal bone. So reading the cross section of the implant, cross section of the bone was very important to understand where our first drill is going to be. So in this case, it is in the apical 1/3, but parallel to the apex. So depending on the cross section, the positioning of the first drill will change. In the cases later on, we will see the drilling done in the middle and even in the coronal 1/3, depending on what cross section of bone we have. So again, placing the implant 3 millimeters below the CEG of the adjacent teeth. In this technique, we have used, I've used an acrylic polycarboxylate crown, which was cut and the palatal pass was discarded, and the labial part was used as a template. So a shell technique to say, so where a temporary titanium cylinder was used and the shell was picked up, and the entire remaining area was built up in paracord. So paracord is one material which I like to use on a regular basis. So you can see the concavity given over here. That is mainly for the soft tissue thickness to be more. So if there was a convex area, there are chances of recession being high. So concavity is always preferred, and maximum polish possible to that particular area, the collar that is going to be submerged inside the tissue. So in this case, the prosthesis was placed. Uh, Here I have used Novabone putty. Now, if I were to do this case in today's time, then xenograph would be my first choice. Any xenograph, because it's not gonna resorb, it's gonna act over there as a spacer material. So xenograph would be my material of choice and not a putty material, which can disperse very easily or which can resorb very easily. So I need a material that's gonna be there for a longer time, because we are looking at contour grafting and not creating bone over here right now. So along with that, a collagen membrane was placed, and a connective tissue graft was taken from the palate, and then the entire area was sutured up. Here we have used 40 Vicryl. Now, Vicryl are multi-braided sutures, so and resorbable ones. So now my choices have shifted to monofilament sutures because the healing is much better and the size would be 50 or 60. So smaller the size, the better the healing. You may require more number of sutures, but the healing outcome is much better with the smaller size sutures and all monofilament sutures. um, I've moved away from the braided or the 3 size sutures for the aesthetic zone. So this was the cross section post implant placement, and this is the healing. Now, capturing this area that has healed because of the temporary prosthesis is very important. So this is an analog technique where we use we take the prosthesis in and place it on a lab analog, and one the entire process is along with the lab analog is fitted into a putty index where we try and capture the shape of the processes that is submerged inside the tissue. An open tray impression post is used over here, and the area that was empty all around was filled with a flowable composite. Now this entire shape is now captured as it is inside the tissue, inside the soft tissue area. So this is placed back inside the mouth for an impression on open tray impression. The entire thing is captured into the open tray post, impression post, and then a lab analog is fitted and a cast is poured. Now we have the exact replica of what we have inside the mouth. The soft tissue contour that is created because of the temporary prosthesis is copied and captured inside the cast. So we can fabricate a custom abutment. In this case, a metal abutment is casted and covered with an opaquer, and final impressions is made, and this is the final zirconia crown that was given. So in this case, few points to what I would say is, one was maybe the temporization or the temporary shape, the way we recorded the way we recorded the shape of the soft tissue in the open tray impression post. So these are 2 3 various different factors I think we can take away from this particular case. Anything we can discuss right now, or should I move along?
I think just
Mr.
move
Buzil?
on, Hemal.
Yeah,
Any
yeah,
questions at
fine,
the end?
fine. I'll just move along. So moving to a case two where again a type 1 defect. Now, ideally in today's time, if the bone and hard tissue quality, like hard tissue and soft tissue quality is good enough, and you have good thickness of bone, then socket shield is the way to go ahead with such cases. So in this case, a lateral incisor was fractured. So we went ahead with performing socket shield where the palatal fragment of the root was removed and the labial part was thinned out and the vertical height was reduced to the crest of the bone. So it was thinned out as much as possible, and an implant was placed. Now, this is a preformed bio-HPP abutment that was placed onto the implant. The patient's old crown was still intact, so that old crown or the old process of the lateral incisors was only used to temporize this case. So the bio-HPP abutment was shaped intraorally immediately after placement, and the same temporary the permanent crown that was available with the patient of the earlier processes was relined with packable composite. No cement should be used in such cases because the cement will flow in the socket area because the implant is immediately placed. So that was packable composite was used to bond that onto the prefabricated abutment. This is 2 months post-op. We can see that we have not lost any bulk of the soft tissue or the hard tissue over here, the occlusal view. So that crown was easily removed because we are not bonded, nothing, just packable composite was placed and it was cured. No etching, no bonding, nothing was done. So that crown came out easily. And the same abutment, so it's a one-time abutment concept that in this case that I can emphasize on. So socket shield and one-time abutment concept where that same abutment was again the final impressions were made in the analog way. Now here, once the crown is ready, the I use the preform bio-HPP or the elegance abutment a lot. So it's a cement retained option. So for such cases, excess cement is always going to be an issue. So um, to overcome that, what we do is we make a die out of the inner surface of the crown. So once the crown is fabricated, I use a bite resistant material or any material that sets quickly and can hold its form. So a bite resistant material is much harder and it sets very fast. So a bite resistant material is injected inside the inner surface of the interior surface of the crown, and a die is fabricated. So the crown is cemented outside, and all the excess cement is removed, as you can see in the pictures, and the crown is then placed back intraorally. So you will have minimum flash or zero flash of cement, or there is no extra cement that is gonna be there. So this is one way of handling cementation of crowns on the implants, where we always make sure that there is no excess cement. So in this case, it's mainly the socket shield one-time abutment concept and the way we are cementing the crowns. That's what I would take back. So this case is now almost 4 to 6 years old. So doing fine. See, you can see there is no excess cement anywhere. You can see the socket shield um, just below the crown at the crest of the bone, and the implant is still 2 millimeters submerged. So this is a 4-year follow-up picture where the soft tissue is healing fine. The papillas have also grown nicely. Yeah, this, this is a 4-year follow-up IOPA where we can see the crestal bone has resolved some part, but it is at the neck of the implant. So moving on to the next case, it's a type 2 defect. Now, these cases are all challenging cases to deal with. Most of the cases have a history of trauma, where in this case it's a class 2 div 2 patient deep bite case, a very high smile line case. uh, if I have to do the SSE assessment for this particular case, it's an advanced case. The shape of the tooth is oval, so replacement of the tooth contour is not that difficult. Apart from that, in oval shaped tooth the papillas are very small, or there are no papillas at all, so we don't need to think about the interdental papilla as well. So the factors that we need to look at from this picture is that there is some swelling on the buccal surface of the tooth number 2-1, and the tooth is the history of fracture. The tooth is mobile. So when we see the cross section, you can see the way the tooth is fractured in slide number 34. And in that same slide, you can see that there is no buccal bone at all. But at the same time, what dimensions of bones are available is 2.4 centimeter in width and 11.8 in height. Now the question comes, like I've told you earlier, that cross section of the bone is very important. Reading the cross section becomes the most important part whenever we are doing anterior implant cases. Even though there is no buccal bone, we need to think about if we can plan the case in such a way that we can place the implant in the same visit or no. So my personal preference is always try and place the implant in the same visit if possible, remove the tooth and place the implant simultaneously, because we are saving on the time frame. If we think about grafting this case to create bone and then place the implant at a later stage, that means we are looking at a time frame of almost 10 to 12 months, because 6 months for the graft to heal, after that implant placement 4 months for the implant in a grafted bone to heal, and then temporization 1 month, and then the prosthesis another 15 days or so, almost a year. So my preference will always be to place the implant immediately if possible. So in this case, we saw the cross section. There was thin bone available, so it was a type of B2 cross section. What we can see. So I try and place the implant immediately. So this is how the tooth look like. Now again, taking the cross section, taking the incision design is important. So we have extended one tooth adjacent to it, taken the vertical incision beyond the mucogingival junction. You can see the biotype is quite thin everywhere. So such cases, healing or there being a remnant of the incision scar is always going to be a issue because the biotype is thin. Once the entire flap is raised, we can see the entire root buccal part, the fractured part is removed. The remaining root fragment that is there inside the bone is also removed. The entire socket is clean. Now there is no buccal bone at all. We can see where the base of the apex of the root is, like base of the socket, we can see that entirely. Again comes the challenge, where should be our first point of insertion of the pallet drill or the twist drill or the lance drill, whatever you call it. So the first drill becomes the most important drill. In the first case that I showed you, the drill was in the apical one third. Now, in this case, because of the way the cross section is, so reading the cross section, again, I want to emphasize on that. You need to understand where you want your twist drill to be. How can you have maximum bone coverage for that particular implant will be depending on your first drill of access. So here we are going in the apical, like middle and the incisal third, the first drill, because we want to be very parallel to the palatal bone while drilling. So the osteotomy has to be in such a way where you can go at a 90-degree with the twist drill, then slowly change the angle and go parallel to the palatal wall. And once the osteotomy is completed, this is the implant placement below 3 millimeters below the CEJ. The entire socket has to be covered with autogenous bone. So in anterior implant cases, anterior nasal spine is the best area to obtain how much ever autogenous bone you want for to cover such kind of defects for a single tooth. So this instrument is a PB Boozer bone scraper, where I am using that bone scraper to take bone from the anterior nasal spine, and the entire socket is covered with autogenous bone first. So whenever we have an exposed implant surface, we try and cover the entire implant with an autogenous bone. Cover that autogenous bone with a xenograft. In this case, it's a the xenograft uses BIOS and the membrane is BIOS collagen. Now, if you can see, the particle size is much larger. Now, what is the rationale between for using a large particle size as compared to a small particle size? We need to understand how the xenografts work. Xenografts per se do not get converted into bone ever. They remain there as a particle size. But what happens is the space between the particles where the blood clot formation happens and the bone turnover happens is where the new bone formation will happen, and larger the particle size, more space you will have. So in the end, in the cross section, what we see is the xenograph particles are encapsulated inside the natural bone. So a large particle size is preferred whenever possible for such kind of contour grafting. Um, Now, finally, this case was sutured with a 6-0 monocrel suture. Now, this was a polydepson suture, I think I was using that time, and this was a resorbable one. Now, I have switched to a non-resorbable polyamide kind of a suture, where because this for such cases the suture needs to stay for a longer period of time, almost 15-20 days, and the resorption should not hamper the stability of the soft tissue. uh, Maryland or a fiber reinforced temporary is given. The patient's old crown was only cut and placed back as a temporary. So this is after 15-20 days of healing. You can see some of the suture threads coming out, some becoming loose. So that is one reason I've shifted away from resorbable sutures. So here in this IOPA, you can see bone particles above the head of the implant. So whenever we are grafting with xenograft, make sure that you are grafting the buccal part and over the implant as well. Because when we graft over the implant, it supports the soft tissue very well. So during the prosthetic phase, if we take cross sections of such implants, we can see the bone graft supporting the soft tissue very well, and it's even above the implant level. Like in one of the next cases, I'll show you the cross sections where we can understand that much better. So always cover the entire buccal surface of the implant, or even over the implant, the contour grafting should be done. So this was almost 4 months post-op. We can see where the tissue levels are. The tissue level is higher in the implant area. So that's when the role of temporization comes in. So in this case, the buccal contour is well maintained because of the contour grafting that we did, but still we need some soft tissue height. So a U-shape incision was taken. The entire small flap was de-epithelialized, and then tunnel and roll procedure was done, where the tissue was tunneled in and rolled inside the buccal contour. And again, the BioSPP elegance abutment was placed. It's a preformed peak abutment. So once the shaping is done, final impressions are made, and then it was temporized. So once the temporization is done, it is kept for almost a period of 1 month. Sorry, where we contour the entire temporary in such a way that we can get good tissue profile. So this is where we started with the implant area, and this is where we ended below the adjacent teeth. So that is why temporization plays a major role in such areas, where you control the tissue slowly, and it takes almost a month's time to get that tissue nice and ready for final impression. So again, the same protocol of creating a die out of the crown, so that you can cement it outside and remove all the excess cement. So when you're taking this crown again intraorally, there is minimum or no cement left. So this was the final cementation. You can see the incision, vertical incision marks still there because of thin biotype. So you will always leave some scarring in such cases. In this case, both are Emax crowns on both the central incisors. High smile line. So yeah, we started with a case with no buccal bone, but because of the immediate implant and the contour grafting and good temporization, we were able to get to where we were in the final result. So this is just the pink aesthetic score and the white aesthetic score. This is just to judge ourselves or our work. It has nothing to do with how the outcome of the case is. It's just us judging our work. That's it. Moving on to the next case. Uh, this is a case where we are going to talk about single implant in a type 3 kind of a defect. There was a roadside trauma accident, bike trauma, young kid, 21 years old, where the 2-1 central incisor was avulsed completely, and the right central and lateral were fractured. So very deep bite, loss of distal papilla, mesial papilla is also lost a bit, and this was the entire contour of the defect, where you can see there is no buccal bone, there is hard tissue loss, there is soft tissue loss. So that's a type 3 kind of a defect. There are no remnants of the root anywhere. And you can see the crest of the bone where there's discrepancy in the height. So that's why the distal papilla is lost as compared to the mesial papilla. Now, studying the cross section of the bone, again, as I emphasized earlier, becomes very important. You can see the fracture line extending to the anterior nasal spine and to the base of the nose. There is no buccal bone at all, but there is good amount of parietal bone that is available. So if we think about such kind of cross sections and we go again with just grafting the entire socket, we are going to lose time. So I would still prefer to place the implant immediately whenever possible. So type 3 kind of a defect. So we are going with the early implant placement because the tooth is already avulsed. So again becomes a question of how we are going to increase the volume of bone, volume of soft tissue, because we have both vertical and labial volume of bone that is lost, and the soft tissue both being lost. So what's the procedure that we are gonna do, or which approach are we gonna take, becomes a very important question in such cases. So this was the flap design that was chosen for this particular case, extending one teeth beyond and going beyond the mucogingival junction. The entire flap was laced. Now, when we are talking about early implant placement, what we need to understand is how the biology works. The soft tissue has healed completely in such cases. There is no bone formation. So in the socket, you can see all granulation tissue. There is no bone formation at all. But once the soft tissue heals, the soft tissue thickness increases. So in this case, we need to do vertical grafting of the soft tissue as well. So what I have done is the buccal flap that was raised, I could feel the thickness of the buccal flap much more. So I have taken a reverse partial thickness of the buccal flap. So in the next image, we'll see that and discuss. In this image, whatever granulation tissues we can see were all removed. All the fracture lines, all the bone that was fragmented and mobile was removed. So this is the reverse split thickness of the buccal flap, where we are splitting the connective tissue, keeping it attached to the flap so it is pediculated. So the blood supply will be intact. So this pediculated connective tissue will be used for vertical soft tissue grafting, and then the flap closure will happen. So we do not like in the earlier cases I've shown you connective tissue grafting, but in such cases, if the buccal thickness of the flap is much more, then you can always use this kind of a technique where you're not creating an additional site for the soft tissue graft. So the entire socket was cleaned. The implant was placed palatally, 3 millimeters below the bone. The entire socket was covered with autogenous bone from the anterior nasal spine. Again, xenograft placed for contour grafting. You can see even the neck of the implant is covered with xenograft. So over the implant also it's covered, and the labial part of the implant is covered. This is a double membrane technique where we have one horizontal membrane and one vertical membrane. So vertical membrane covers the entire area, over that a horizontal membrane. So this stabilizes the graft in a much stable manner. After that, a mattress suture is given. So you can see the distance between the two threads of the mattress suture. It is to hold that graft firmly in that area, because we want that entire buccal bone, because the buccal was lost. Implant, hardly some threads of the implants were exposed, but we need that volume for the aesthetics. So we need to graft that area very nicely and make sure that the graft is stabilized for a longer period of time. Then the buccal flap that was made, the partial thickness reverse splitting that we had done of that connective tissue is sutured first. So right now we have the implant. Over that we have autogenous bone. Over that we have xenograft, both on the labial and the occlusal surface. Then two membranes, and then the connective tissue is sutured. So we are trying layer by layer to increase the vertical height of the tissue, both hard and soft tissue, and then the entire tissue is sutured. So once the suturing is done, the implant is in place. This is what we have at 15 days. The entire week, like in 15 days, you can see the entire volume of the entire grafted volume can be seen. So same way a temporary was made as in earlier case, fiber reinforcement, and a temporary crown or a composite crown was made. Now, in such cases, there's always deep bite. So this is one way where I prefer to hollow out the inner part so that the lower teeth do not interfere with them. So when we are placing the fiber splint, we make sure that it comes forward in the center. I don't know if you can see properly, but if you can see the flash, the center line, so that part is ahead than the rest. So that's why the flash is shining very nicely. So uh, we make sure that the center of the fiber is in the center, and you have a hollow out area in the palatal part, so that the lower two don't just lodge the tongue. So we keep that for a period of 4 months or so. So during the second stage, again, a palatal roll technique was done, but at the same time, I have used a small gingival former. Now, short height gingival former, what advantage it has is that the soft tissue grows over it. Right now, we are in the need of whatever soft tissue volume we can get. So after the healing part happens, again, the same elegance abutment is placed and temporary crown given. Again, for a month, the temporary crown will stay and final impressions made where adjacent tooth is prepared for a veneer, and this is for the final crown. So we can see some shaping of the tissue because of the temporization that we have done. Tissue levels are matching. Same way, a die is made, cementation is done outside, and the crown is placed back in. So this was the final crown. From where we started, there was no buccal bone at all. There was no soft tissue at all. There was loss of hard and soft tissue both in the vertical direction, type 3 typical defect. You can see the nice stippling of the epithelium, nice keratinized tissue, a very high smile line case again. Yeah, so this is the cross section that I wanted to emphasize on, where I was telling you that we have to be two, three things. One, when we are doing our osteotomy, we have to be bang parallel to the palatal wall. So this is all freehand. Right now we are talking about analog. Now, why I want to emphasize right now on the analog part, because in the digital part, we do the same thing. The planning remains the same, but now we are planning everything digitally. So the advantage when we are going to do planning digitally is that we are going to be very, very less invasive. So in this case, the implant is banked parallel to the palatal wall. If the implant ends somewhere over here, this is the abutment area that starts, but you can see the bone graft that has been added is over the abutment. Now, why I was asking you to place the bone graft above the implant as well, because this bone graft supports the soft tissue nicely. And that is why when we are doing contour grafting, xenograft is the material of choice because it does not resorb fast. It takes years for it to resorb. So the soft tissue is supported by the bone graft as well, a dual zone grafting kind of a thing, but not loading it immediately. But yeah, something similar where the soft tissue is supported by the bone graft. So again, a person was score. Now everything was fine for this patient for about a year and a half or so. After that, the patient came to us with some amount of recession. Now we know that we have placed an implant at a particular angle. Maybe that could be one reason. We have not done any additional soft tissue grafting apart from the split thickness that we have done. So whatever the reason may be, now because of a high smile line case, young young guy, 21 years old when did his treatment. So now during the follow up, he was 23 or so and moving to US for further studies. So we had to do something for the recession. Now we do not want to, like, we can get away with some pink composite, but will the recession stop at this stage or not? We are not sure. It can increase. So our preferred choice would be not to disturb the prosthetic or the harmony of the entire structure that has been already been made. So I went ahead with a procedure called tunneling technique, where we did tunneling and added connective tissue. These instruments or the blades, they are called as keratomes. They are used in ophthalmic surgery. They are very fine blades. So I use them for tunneling, and this is one of the tunneling instruments that I have. So tunneling instrument was used. The papillas have to be intact for this procedure. So connective tissue graft was taken from the palate. Single incision technique is my preferred choice. So yeah, a connective tissue graft from the palate is taken, and then the entire connective tissue is pushed in. It is stabilized on both the ends so that the connective tissue does not move, and the entire tissue is then pulled and sutured onto the tooth, so that the soft tissue needs to be stable in that area for a period of at least 1.5 month. So for such kind of procedures, you need sutures that are not going to resorb easily, have good enough strength. So a 5-0 or a 6-0 monocryl, in this case, the 6-0 monocryl suture is used. So monofilament 6-0 suture. Yeah. So this was after a few days, after 24 hours, the healing. And this was the final healing for that particular case, where you can see the volume of the soft tissue has increased tremendously. After that, I have not seen the patient. It's been almost now 6-7 years, but yeah, I have not seen the patient after he went to the US. But this is what we have lost some distal papilla in here because of the tunneling and everything that we had done. But we need to be very minimally invasive in such cases where we find recession. Moving on to our next case, where this case has been like a learning procedure for me, I would say. If I look back, I I would have changed many things right now, what I am doing. So mainly I'm going to share with you my experience, what all things I would not have done, which I'm going to show what I have already done in the past, in this particular case also. So this patient was a consulting case. The doctor had sent me a picture with a swelling on her left side that was due to a fractured, that was due to an infected canine. Now, these were the images that were sent to me. So what we can see is the reverse smile line completely, where the patient was not that happy because her teeth were not that visible. Lowers were also failing. So this was the OPG that was taken at that time. Looking at the CBCT data, there's one more tooth that is present. If you can see in the OPG also in the center part, there's a tooth which is already present in the bone impacted. Again, in the cross sections, you will see yellow arrows where they're showing at what position the overall impacted tooth is. Cross section of the bone shows around, maybe in some areas, the 4.2, 4.9, but then it has a big concavity. If I were to do this case today, maybe I would go complete digital and place the implant simultaneously and do the grafting. But this is what we had done at that time. So yeah, we went ahead with the prosthetic planning. So planning and everything will not change. So we did a prosthetic planning according to the patient's wish, where she found that uh, her smile was not good. So we did reverse engineering and made sure that we correct the reverse smile line, have the prosthesis in place, and the defect that was remaining were covered with pink wax. So when we made a temporary check intraorally, this is the amount of hard and soft tissue defect that we are looking at. At this stage, we discuss with the patient the different treatment options. Either we can go with the current level and give you a prosthesis which will be white and pink, or we can do some amount of uh, block grafting, and then make sure that we go end up with only white. But she was not happy with the idea of a second site, so we and she was okay with the white and pink part. So that is what we went ahead with. So first idea was to do just grafting and no implant placement. Now this was early days, and I tried my first or second socket shield trial. I mean, I would say to do a socket shield in the canine. Uh, but that was a blocker approach. I mean, I did the shield, but I did not place the implant that day. So we left the shield intact over there. Now you can see the entire defect, concavity which is present. This is a BioGuide box. So whatever you can see on the top is the autoclaved sheet which is available in the BioGuide pack. So that sheet was taken, and then a outline or a cutout was made about the size of the membrane that we want. So below you can see the entire square shape membrane. So this size was chosen, and the membrane was then cut into exact size, because we do not want to touch the membrane unnecessarily, because it's becomes very messy once it touches any saline or blood. So this can be one tip where you can just use the wrapper which is already sterilized. You can use this as a template for the shape of your membrane. Perforations were made in the bone. The sausage technique was used in this case. Now, sausage technique is where um, you use, I mean, I would say BioGuide in a way. You can use any membrane, but I don't think I've used any membrane which is as elastic and as malleable as BioGuide is. So in this case, BioGuides and bone packs were used. You can see one of the tacks loose on the right side. We realized it later in the photos. So tacks were used. The four tacks were placed palatally. Then on the left side, two tacks were placed on the top and one tack on the distal. And whatever opening we see over here in the center, the bone is pushed inside as a sausage. So this is what sausage technique is, where you build up the entire area with bone graft. So this is a combination of 50% bone, xenograft, and 50% autogenous bone. So autogenous bone was scraped from the anterior nasal spine and the root tuberosities of the adjacent teeth. So whatever amount of bone we could collect, we mixed it with xenograft. And this is the final sausage where we have packed the membrane from all the sides, and the entire closure was done. So again, here bilateral sutures are used, which I would not prefer now. The temporary that was made was given on that particular day. Now, after some days, after 6 months, this was the cross section of the bone. So we had good volume of bone. Now, again, at this stage, this was the temporary that was given. I think what I would change if I were to do from this stage, I would not open the flap at all. I would directly go guided and save the volume of soft tissue that I have made. But uh, at the knowledge what we had and what I had that time, I opened up the flap. I can see good volume of bone, but I should not have. So if I were to think today, I would not open up the flap at all. Just place the implants guided. and give a temporary, because more number of surgeries we do, more hard and soft tissue volume is going to be lost. That's a fact, and that we cannot deny. So this was the third set of temporaries for her. After 4 months, we saw again the cross section. The implants are away from the impacted teeth everywhere. We have good amount of bone on the labial surface of the placed implants. So now with such high smile line, we were just working on the final outline of how the process is going to be and what kind of materials we are going to use for the patient prosthetically. So open tray impressions were made. It was a malo kind of a bridge design where we used peak material as our framework and individual Emax crowns were given. So this was the designing for that. It was, yeah, this is the framework design. It was milled in bio HPP peak with from Gradient, and then it was bonded onto the abutments. Yeah, so this is the final framework design, individual Emax crowns. So this was a wax trial for the aesthetic part, and the final Emax crowns ready for bonding. Yeah. So this was the final crown and intraorally, and this is how it looked with a malo kind of a design. So the pink composite done by the lab and by me to cover it, to cover the excess opening, it's not matching. So yeah, but the patient smile is much higher than this. We have seen in the earlier photos. So it's a very high smile line case. So this is how I ended up in a type 3 kind of a defect. So this was some analog cases that I wanted to show and discuss what all protocols I had been following and what I have changed over the years to digital format. That is what I want to discuss from the next cases. Uh, Anything you want to discuss right now before we start with the digital part?
Well, we just have one question currently from Dr. Amir, and he's asking, is that the large particle size xenograft
Yeah,
is that after the healing period, I could see some of the xenoparticles in his experience protruding
yeah.
from the mucosa, especially in a thin biotype. So I want to ask if what is your stand on this? And because some of the literature also suggests the use of small particle for GBR.
So large particle, I mean, any xenograft is going to be protruding in a thin biotype case, or it's always going to be there. My experience with such cases where I have opened up flaps is the use of large particle size. But in cases right now where I'm not opening the flaps, even with no buccal bone cases with going digital, we are going without even raising a flap. That time I'm using small particle size because the area where we are working is very small. So large particle size, I've shifted to a small particle size right now. But in so those kind of defects where, because the way xenografts are healing, they are encapsulating like the natural bone is encapsulating the xenograft. So more space you have, the more space will be available for natural bone to form. So that is what my experience is.
Okay. Another question is as regards the sutures, Hemal. In your
Yeah.
cases, you've shown a variety of sutures that you have used in different situations. Could you just emphasize on what is your preference in terms of suture selection when you are doing
Okay.
contour grafting or a sausage technique or various different grafting techniques versus a normal implant placement?
Okay. So normal implant placement, if we are doing a 4-0 monocryl, any monofilament 4-0 polyamide is fine enough. Okay. But whenever we are talking about any soft tissue procedure involvement, move to 6-0. Same non-resorbable sutures, but in a 6-0 format. Move away from 3-0 at all and move away from braided sutures and resorbable sutures completely.
Okay,
So
that's
that's
great.
my like 4-0 and 6-0 monofilament, any polyamide sutures should work.
Okay. Also, lastly, to just what is your stand on the rationale of using bio HPP abutment as a one-time abutment that you used in most of these cases?
Yeah, so I am in love with that abutment because the soft tissue adheres very nicely to it. And right now I have shifted to customization because we are working digitally, but still I that would be my first preference if the height of the soft tissue and everything is, allowing me to work with that, because it has a standard height of 3 millimeter collar. So if that works, then I would still use that abutment. I mean, so that's why you will see less cases for me which are cement screw retained, and more cases which are cement retained, because the abutment works really fine. We can deliver the process immediately to that patient rather than depending on the lab. So as I'm planning most of the cases to be immediate implant placements and immediate loading, so I work with that abutment a lot.
Yeah, so talking about the collar heights, Hemal, also, would the level of implant, vertical level of the implant placement be critical in terms of providing a good emergence profile?
100%. So as I showed in most of the images, that 3 millimeters below the CEJ should be the neck of the implant. Anywhere below or anywhere higher, if we are higher, then we will lose the soft tissue, because we do not have the room for the soft tissue to, there will be no breathing space for the soft tissue if the implant is less than 3 millimeters from the CEJ. And if we are talking about implant being more than 3 millimeters, the bone has to be such good quality that it would support the soft tissue also. So looking at Turner's principle and all these things where we talk about from the contact point to the crest of the bone being 4 to 5 millimeters maximum. So in that we are talking about 3 millimeters from the CJ to the crest of the bone, like something similar. So that height matters a lot.
Great. So I think you can proceed now.
Yeah,
Let's switch over to the digital aspects. Yeah.
yeah. So before starting the digital aspect, I'll just say that um, I'll try and tell you the softwares that I have been using along with it. So some softwares I have, some softwares I work with lab. So and all the cases that you will see, the guide printing, all the temporaries is everything is in-house 3D printed temporaries and the guides. And I work in collaboration with one or two labs which who have those softwares and who understand what I want and what they want. So yeah. So moving on to my first case is a type 1 defect again. So I'll try and show you similar cases what I have showed in the analog way, and similar cases how I have done them digitally. So in this case, lateral incisor was fractured. So this was a digital planning. This software is Blue Sky Bio. I have prepared a socket shield of the entire root, how it should be. So you can see it is at the crest of the bone, and as much as thin possible in the software. So I placed my implant accordingly. It's a 3.5 by 12 or 14 millimeter implant. So implant position was planned accordingly. So the shield is not separated digitally, it is all manual. But at least I know how thin I can go and where my implant position will be to the shield. So again, talking about implant placement and temporization, um, this is a burr from Comet, 31 burr. So I'll tell you my protocol for socket shield preparation is I just go through the center of the. So first, understanding the cross section of the root is very important, where you can see if there is no curvature in the root or not. So the way we do access opening for our endo, we need to have a good tactile feel while doing a socket shield, where you go through the canal, go beyond the apex, have that feel, then slowly have that feel of the dip into the bone, then slowly come out, go laterally, separate the tooth from both the sides, mesially and distally, and then slowly remove the parietal fragment. So the entire fragment was out. Then thin the shield as much as possible. Take the height below till the crest of the bone. So this was the guide placement. Now this guide is made from a material called as Edtech guide resin. It's an Indian company. I am using Accurata guide resins right now. So, so there are many. Yeah. So this is slow drill speeding. So slow drill speed. So this is the final osteotomy. So in final osteotomy, I drill at a speed of 100 without any irrigation. or maybe external irrigation if possible. And this is the implant placement in position. So we have to match the hex of the implant to the hex of the metal sleeve. So in most of the cases, you will see me matching that. Now that is as per what we have planned in the software, the hex to hex matching is done. All the implants that you're seeing in the cases are from Brident. So this is a Brident guided kit. The guide is removed. And as in the planning, you had seen that the implant was quite close to the shield because there was not much space. So this is a 3.5 implant. So it is just little spaces available between the shield and the implant. You can see the blood seeping in that area. So little space is available over there. So it has ended exactly where I have ended my prostate. I mean, I have cut the shield. So to the crest of the bone. Now, this was a 3D printed temporary, which I had prefabricated. You can see the wings on the adjacent tip. They are there for the temporary to be stable. Orientation, maybe you can say orientation wings, so that the temporary does not move. So we spoke about the BioHPP elegance abutment. So in this case also, I have used the BioHPP elegance abutment. The entire tooth is hollow from inside right now. So what I have done is I've taken packable composite and just placed it so that I can get some contour. I'm not cured it. I take it out, cure, and whatever space now is available, I'm gonna have an access opening. So prosthetically, we knew that this crown is gonna have a labial access because of the cross section of the bone. So, but the abutment height is very small in this case as compared to the earlier cases. So yeah, this is again paracord covering the entire BioHPP elegance abutment. Processes back into place. That is why the orientation wings are important because the process has been designed as per the occlusion. And again, a deep bite case. So the process is picked up with the BioHPP abutment. It is then finished, polished, whatever excess is there is removed, whatever deficiencies there's filled with paracord again and polished highly, then placed back. So this is how the abutment comes out. After finishing, it has been placed back and then torqued in. So yeah, final torqued in, and then this is the temporization. You can see out of occlusion. This is the temporary immediately after the surgery. So after 3 months or so, 2.5 or 3 months, we had used a scan body to scan that area. And this abutment is called as Unifit CAD abutment, which is used to fabricate this monolithic zirconia prosthesis. So Unifit CAD abutment is used. It is the process is designed and it is bonded onto the Unifit CAD abutment using dual cure resin cements. So, and this is the final crown. So this because uh, like because of the digital part, we know exactly how the implant is gonna be. Again, I've shown you different types of temporization in the earlier cases. So in this case, the temporary was a bit different. So every case, I'm trying to show you where uh, you can emphasize on the cross section of the bone, emphasize on the way the implant is being placed immediately or delayed. Provisionalization is being emphasized, and reverse engineering in digital is now what we are gonna see. So the key points that I wanted to tell you are those. So this is again a case of a type 2 defect, history of trauma. There is no buccal bone. So again, the software used over here is Blue Sky Bio. It's a free software. So the prosthetic crown was chosen, the implant was chosen, the abutment was chosen. Again, uh, you can see the cross section. You can see the blue line over here. This is where the buccal bone ends. There is no buccal bone over here. So there is hardly very thin buccal bone that is remaining over here. So the cross section is also very tricky, where getting an implant stability would have been difficult. But this is how the guide was designed. I again kept the temporary design ready. If I get good stability, I would have loaded it. If not, then same processes will be used as a Maryland kind of fiber reinforcement, as shown in the earlier case for temporization. So the tooth was, so this is how the fit of the temporary was. The tooth was removed. This arrow is the area where I could feel some amount of buccal bone. So that is even beyond the mucogingival junction. So there was no buccal bone at all. So again, the guide was placed, the implant was placed. There was not much stability. But then for such cases, what I do is I take a connective tissue graft. Uh, I suture it beyond the mucogingival junction on the top, and whatever space is remaining between the connective tissue and the implant is filled with small particle size xenograft. And then the connective tissue is sutured onto the entire socket opening. So in such a small area, we are seeing about maybe 12 or 13 sutures. So this is how a 6-0 suture non-resorbable should be used for such kind of areas where you should graft it completely. Now, we are talking about a small particle size graft which has to be packed completely into whatever space available between the connective tissue and the implant. In the earlier case, you had seen me opening big flaps for such kind of case where there was no buccal bone. But now, because of the guided, I know where my implant is going to be placed. I am 100% sure that this is the position where the implant is going to be. So I don't need to see where my drilling is going to go. Now, coming to the second part, I am not cutting the periosteum. So periosteum is intact. So I'm using a connective tissue to stabilize. So I'm getting my volume of the soft tissue by adding connective tissue. At the same time, the buccal bone that is missing will now be covered entirely with the connective tissue graft, with the bone particle size, small particle size bone graft. So now again, the temporary is splinted onto the adjacent teeth immediately. This is how the splinting is done. And again, in this case, bio-HPP abutment is used, and this is the temporization image. So this is how it looked with the temporization. You can see small particle size in the gingival collar. So that is very typical of a xenograph. If some comes out, that's okay. I mean, that is very typical. It will happen always, even with small or large. But importance of temporization, where you can see nice scalloping of the tissue, papillas intact. So there was no buccal bone at all. Final shade matching in this analog uh, impressions were made, and this is the final crown. So yeah, this is a Emax crown that was bonded onto the bio-HPP abutment. So main advantage that I want to emphasize in such cases that we do not take big flaps as earlier. So that is the beauty of going digital. So a similar case, uh, history of childhood trauma 2-1 is fractured with external root resorption, no buccal bone at all. The tooth was firm when the patient came to us. We were undergoing aligner therapy for her, but midway aligner therapy, that tooth started moving a little bit. And then that is when we decided to let's do the implant first and then we'll continue the aligners later. Because initially she was not that keen on replacing that tooth. So this is how the tooth was fractured. You can see the fracture line over here. Yeah. The same protocol as I did in shown in the earlier case, but now with a video of the entire surgery. So temporary was planned. If we can do it immediately, fine. If not, so that's why the length of the temporary has been kept short. So you can see there is no buccal bone at all. The incisive canal is also quite wide. You can see the implant height. So the amount of depth of implant placement is also larger in this case because the parietal bone is also that below. So this case becomes very challenging. And because of the digital part, we are doing it completely flapless. So once you see this, the entire tissue will collapse. You can see the tissue collapsing from the guide. So the implant was placed, hex and everything was matched. See the entire tissue being collapsed, no buccal bone at all. So single incision technique, taking the connective tissue from the palate. So these are long instruments for microsurgery that I'm using. A normal 15C blade is used. So the way it's done is you take a single incision, release the entire thing from the palate with the periosteum, then hold the tissue, do a split thickness between the connective tissue and the outer epithelium, then do two vertical cuts and finally from the bottom. So that is what I follow. The entire tissue is then placed in the socket and then sutured in such a way that it is beyond the mucogingival junction. So suturing up the palate area started to bleed a bit. So in the palate, I prefer a 4-0 monocryl. So this is a monofilament 4-0. And in the area of where the graft is going to, because 4-0, why? Because the needle is longer in 4-0. So it becomes easier for the palatal area. And in 6-0, the needle is much shorter. So for areas where we are doing soft tissue graft area, so 6-0 is preferred over there. The graft material being used over here is also a xenograft, but it comes as a combination of a xenograft and collagen. It's very packable friendly as compared to only a normal particle graft. This bone graft, you can see I'm giving very nice shape. It is staying there. Uh, this graft is called as S1. It's a Korean bone graft. It's not available over here, but it's a combination. So something similar to a BIOS collagen. So now the entire implant, the buccal area is grafted. On top of the implant, also everything is grafted by this, and then the entire connective tissue is sutured. Okay. Moving ahead, this was the final suturing. You can see 6-0 small sutures. So that is what you would prefer, how much ever sutures possible. So in this case, the temporary that I have used is a 3D printed Maryland bridge. So instead of using the fiber reinforcement, this is a 3D printed temporary that is bonded onto the adjacent teeth. See from the palatal part. So yeah, this is how the process is stayed for almost 4 months. So then the scans were made. Now the beauty of digital part, you can see the scan body is hardly visible, but the matching came out accurate. I am using a Medit i500. It's not one of the best. It is not the worst. So I'm using a reasonable standard scanner. So with that also, I'm getting good results with the scan bodies and everything from whatever protocol I'm following. So this was the matching that was done in the software. Again, in this case, before moving on to the final, temporization is the key. So a unifit abutment was used to make the temporary. So you invest a lot in such kind of aesthetic cases, but yeah. So this is how the entire temporary crown was fabricated and then placed intraorally. You can see the labial access opening for the crown. So it will be a custom abutment that has to be fabricated to have a good aesthetic result. So because of the temporary, which we kept for a month, this was the tissue profile that we got. You can see the implant is quite deep seated because there was no bone at all to begin with. So again, the final scan, and this is a bio HPP pre-mill. So earlier I've shown you elegance abutment, which are ready-made or pre-formed. Now this we have to customize. So a pre-mill blank block is available for bio HPP. So we have used that, and this is the abutment design. So a block, something like this. So yeah, so this was the abutment placed, final shades taken, and this was the final crown. So yeah, again using two types of abutment of unifit CAD for the temporary and biosweep pre-mill for the final. So such cases require time, and but we can be minimally invasive, and digitally it helps us a lot. So moving on to the next case, this is a yeah, this is a type 3 kind of a defect where we have lost hard and soft tissue both. A old bridge had failed. You can see the high frenum. Again, the planning remains same what we had done earlier for the type 3 kind of a defect, multiple teeth missing. You can see the hard and soft tissue loss in the labial part as well as vertically. So the frenum being too high. So the case was planned digitally. This is a 3D printed temporary which was made with a Maryland on the canine on the opposite side. So this is the surgical part. So three implants were planned in this case. I think the planning images have been left out. Yeah, but three implants were planned. So a full thickness flap was made. That tooth was removed. The guide placed intraorally. So initial osteotomy done. Implant placement. There is no threads exposed. So in planning, even though there was a big defect, deficiency of the labial bone, but the planning was such that we get minimal exposure of the threads. In one of this implant, there was the angle was such that we would have had some kind of exposure. So I just want to show you how precise. So you can see some kind of thread exposure over here because the bone was quite thin, and this was in the extraction socket. So cutting off the frenum first. When we talk about flap closure, whenever we are grafting, we need to have good release of the flap. So there are two, three ways of doing it. One is to cut the periosteum, but I prefer this in the upper jaw more, and some to some extent the lower jaw, where I'm stretching the periosteum. So this instrument is a bone scraper, but I'm using it to stretch the periosteum rather than cutting it. So if we cut the periosteum, it bleeds a lot, and the healing is also the swelling amount of swelling that will coming for the patient is also much higher. So stretching the periosteum is a key. So again, this is the same material that I told you earlier, S1, a xenograph from Korea. You can see how well you can pack this material. It stays there, it becomes firm. I'm placing the graft labially and onto the occlusal surface. So it has a ratio of the water content or saline content that you have to put in. And then if you use the exact ratio, it sets quite nicely. It gives you that shape. It's something like what we get out of PRF liquid and a bone graft. So something of that consistency, sticky bone kind of a thing. Yeah. So the entire area was sutured with a 6-0 monocryl, and this is the second stage. Now in second stage, there is no characterized tissue. So what in this video you will see is like earlier you have seen connective tissue graft. Here you will see epithelial, full epithelium graft. So this is a split thickness apically position. So in a way, a vestibuloplasty that is being done. So a split thickness incision is made, and then apically it is sutured with a 6-0 suture. Yeah. So measuring what the length of the graft that I would need, and then the entire length that is required is then taken from the pallet. Slowly start the dissection from all the corners. Full thickness epithelial graft is then taken and then placed and then sutured. So I think the suturing takes about an hour for such kind of cases. Uh, you can see, I don't know how many, but all this has 60 micro sutures, and the graft has to be completely adapted to the base of the the split thickness that we have taken. It has to be adapted nicely to the connective tissue. Only then will it be taken up. Collagen plug were then sutured onto the palatal area from where we had taken the graft. So this is how it healed up. You can see now good keratinized tissues, scan bodies were placed. Again, unifit CAD abutments were used. So yeah, the scan bodies into the, so the yellow one is where we started, and the pink is the thickness that we have right now. So we have good hard and soft tissue volume gain. So these are the unifit CAD abutments, prosthetically designed, and then individual abutments were designed accordingly. So this was where we started, and this is where we are. So as compared to the earlier case that I had showed you about class 3 defect, so things have changed drastically because of the digital part. So this is how the abutments are in place, temporization, and this is the final for that case. And this is this patient smile. So moving on to two more cases and we'll be done. This is a small case, we'll finish fast. In this case, lower anteriors were to be replaced, but then this was a patient who was gonna travel back. He was an NRI patient, and we had to do the implants and load the case immediately. So you can see the defect, but we were not gonna do major grafting for him. So we wanted to be as minimally invasive as possible. So the implants were planned and in such a way that the guide was fabricated, but a model was fabricated of the exact implant position before the surgery. So this is the model of the case before the surgery. And two Emax abutments were designed individually for him and bonded onto the Unifit CAD abutment that I've shown you earlier. So this is how the guide seated intraorally. So this is the surgery for this case. We had planned for two implants. This is a tissue punch. Uh, Removing the tissue tags. Guide placed again. So this resin is from Accurata Sole. Uh, yeah, Accurata guide resin. So with the guided surgery, we can just, once we know the planning is fine, we can just move ahead and finish such kind of cases within half an hour or so maximum with the prosthetic part. If everything goes as planned, nothing should be an issue. So this is the final drilling for that case. So implant placement as per the planning. Implant torqued into the position that we had planned. The guide is removed, and the abutments that were pre-designed for this case, which we had seen on the model. Yeah. So you do complete reverse engineering for such kind of cases. The abutment goes into place as planned. Now, with my experience in such cases, I have designed the temporaries beforehand, but then they don't fit as well because there is some or the other soft tissue changes. So I took a scan after fitting the abutment, and next day had the new temps ready for him. So this were the abutments and this were the temps after a few days. So last case that I want to discuss is not an anterior implant case, but it's a full mouth case, but I'm working on it. I'm working on some protocol that I want to share with you guys. Um, so here it's a lower edentulous case. Dual scan technique was done. Denture was fabricated, scanning was done, and the denture was scanned separately. So that is what a dual scan technique is. So this was a temporary that was made beforehand. Now in this case, you can see that the opposite teeth are natural dentition. One of the major problems when we are doing such kind of cases is the loading part. And for that process to stay, we need some kind of metal reinforcement. So we have been working with intraoral welding procedures earlier, but now with digital part, with the reverse engineering and everything, we are designing and this is one way I am designing the metal framework and that goes into the processes. So this was a design for one of the metal frameworks for this particular case. So it fits in right as a slot inside the denture. So this is how the entire denture. So the denture is printed, 3D printed, and the metal framework is bonded inside. And you can see all the openings of the abutments. So this is how the guide was fitted intraorally. So stabilization pin into place. Let's move ahead with the prosthetic part. So drilling protocol and everything will remain same, sorry, as to what you had seen earlier. Implant placement is also the same way as the earlier cases. Yeah. So now we start with the placement of the multi-unit abutments. In this case, all were 0-degree abutments. We torque them in, we place the metal cylinders, and see how well or how passive the entire process just goes in. Mhm. So all the 6 metal cylinders are in, and the process just goes in the exact planned position. You can see the entire opening. You can centering of all the abutments. Okay. Now we just need to pick them up, cut the height of the abutments to the prosthetic level, and then finish and polish it off. So the material, as I have my first choice of material in always such kind of pickups is again paracord. So you can see the metal framework is already bonded inside. This just goes in nicely. I'm using paracord to pick it up. So some amount of paracord in all the drills. So why I'm using paracord is because it is a very good consistency. It's not too flowy, not too viscous, and it sets very slow. So it gives a very long working time. It's a dual cure resin. So this is how the prosthesis was finished and then placed inside and screwed in. So there are two protocols that we are working right now on. Is one is with the metal reinforcement for such kind of cases, as you saw. So this was the prosthesis. So this was after a few months, 2 months or so. Yeah. So this was a OPG with the prosthesis on, I mean scan. So this was the planning scan. Okay. And this is what we saw intraorally. So you can see the implants being placed at the positions that were planned. Now moving on to scanning of the lower arch for a full mouth case being one of the most difficult things to do. Forget about doing it. Having the results being replicated in the final process is also very important. So the protocol that we are like working right now, we have done about 2 or 3 cases. Uh, Taking the vertical, the centric, and FI with scanning in one step only. So the prosthetic part for a full mouth rehab can be done in 3 steps, 3 visits. That's the protocol that we are working on. So the fast and fixed scan bodies are placed on the multi-unit abutments. A bite is taken as per the vertical what I felt on her face and speech, or whatever criteria that you want to choose for vertical dimension. So bite was taken. The scans were made according to that vertical. A temporary prosthesis was fabricated. Now here I've used a model resin. You can use temporary resin, whatever you want. But the same temporary was then checked. This so these are all implant lab analogs fitted. So this is how the lab analogs are fitted into the 3D printed models. So this entire process was designed. The metal abutments were then cut according to the prosthetic height. You can still see some screws of the prosthesis of the 3D printing. So this is how it looked like. So intraorally, I placed the multi-unit abutment, placed the process, and it was bang onto the occlusion that we had planned, and it was completely passive the way we had planned. So the idea is to have the scanning done, vertical taken in the same appointment. And if you have a trial process is ready within a day, because everything is in-house, I'm doing it within a day. And if everything is approved by the patient, if I don't find any changes to be done, the same design is milled into zirconia directly. So this is zirconia from Britain. It's called Luxor. Now there are many zirconias in the market. Now the advantage of Luxor, it's a 6-layer zirconia. There are other six layered zirconia available, but this is one of the only or one of the few zirconias which has gradation in strength. The base layer is around 1100 megapascal, and the top layer, which is going to come in the occlusion, is at 720. So the major issues that we had with zirconia of wearing of the opposite dentition, it is the 720 range is coming close to what Emax or uh, coming close to natural dentition. That is what the entire idea is. So this is a zirconia, monolithic zirconia from Luxor. So this is the exact same copy of the trial that we had taken. Yeah, so this is how it looks. So was on the trial, and this is the final zirconia that we milled and into trial, and this is the final prosthesis. So within 3 steps, the entire case is over for a full mouth rehab if we do the scanning correctly and the bite precision correctly. So yeah, thank you. I think we have extended by some time, but yeah, these are the cases that I want to share with you.
Thank you very much, Dr. Hemal, for a fantastic presentation. And I'm really amazed to see that being a prosthodontist, you've shown so many surgical protocols over here in all different ways of grafting. Yeah,
Yeah,
that's really nice. Okay, before we take some questions, I'd just like to make some announcements. So if you can just stop your sharing.
yeah, 1 second. Yeah.
Yeah, okay. So then I reclaim host, and so what I would like to do is share with you as regarding our upcoming Congress that we are going to be having on the 31st of March and the 1st, 2nd April under the title of Digitize 1.0. And we're going to have a series of pre-conference workshops, which we'll be announcing shortly. We have great international speakers of repute, which also we have a confirmation of a few over here, as you see, and some more that we'll be announcing in the coming weeks. Also, all our sponsor companies who are supporting us during this Congress. And the important part is we have media partners with dental technology and dental experts. Also, we have now collaborated with the IDD, which is a Digital Dentistry Society, and we are going to be opening out special offers for membership and content being accessed on their website for our members. And a special thanks to all our sponsors who are supporting us, our special event sponsor as well. And we will be opening up registrations in the coming week. So stay tuned. And the next thing that I would also like to inform everybody is that during this Congress, we will also have a poster presentation under 4 categories, which is clinical innovation, digital techniques, and digital case reports, also original research articles. And for each category, we have some fantastic awards in store for the participants. Also, these 4 winning participants' posters will be published in the Dental Experts or Dental Technology publications and circulated in the Asia Pacific edition. So we look forward to contribution from everybody on this front as well. So getting back now, I think we will get on to the questions. We have some questions here. One of the questions comes from Dr. Rijuta, who's asking, how about using the OSIX Volumax by Dentsply instead of the connective tissue graft? Your opinion?
You cannot beat teacher. I mean, a connected tissue will always give you better result than any other substitute. So I've used Volumax 1 or 2 cases. Um, I have not liked it. I know a couple of friends who use it on a regular basis. I would compare Volumax to maybe like if so. I think Volumax is not from Dentsply. Uh, it's a different company, but uh, Volumax can be compared to Bios collagen because it's again a mixture and it's a thicker one. I don't think it should be used as a substitute for connective tissue graft. It can be used for contour grafting. That is what my knowledge is about Volumax. For substitute for connective tissue grafting, there are some materials available from for connective tissue or epithelial. There are some materials available from Bios, I mean the Chrysler company, but I've not had much experience with them. And apart from that, they are too costly. I mean, for a for the amount of graft that I took out for the last full large upper anterior case, that would cost me around 36 or 40,000 for that size. I mean, I don't think patient will also agree. I mean, I'm financially, I don't think it's that viable as of now. I have no experience using those kind of materials.
Yeah, so I think just to add on there, yes, you could use any of the artificial substitutes, but cost is a big factor. And of course, even predictability. I think what connective tissue can give you is the best. So you can always add it up as an adjunct. The
Yeah.
next question is, how do you maintain hygiene? This comes from Dr. Millen, below the fixed prosthesis during the temporary phase.
So water flosser and oral be the super floss. These are the only 2 ways, be it temporary or the final, to maintain hygiene. And there is going to be resorption. So the water flosser should be the best way to do. So
Yeah,
that's
so
the only way. So
education,
these are the only
education.
2 ways we can do it.
The other thing what I can add on is maybe the contour, the interclear surface of the
Yeah.
prosthesis can be structured in such a way that you give a more convexity there and try and avoid food
So
trapping over them,
so what
which is not
my
always
take,
possible, of course.
yeah, which is not, and what my take on that, to some, maybe some, it will be my personal take, but when we are loading opposite a natural dentition, where the bite is going to be strong, like the last case that I showed you, the upper teeth were worn out to a good extent. So it's a very heavy bite patient. So I would like to take lingual extensions of the ridge into consideration and to my support against the loading that is going to come. So that time having a concave part, a concave interlingua surface is going to be inadequate. So having a nice convex surface over there, that you are reducing the thickness of the prosthesis in a way and losing the support of the lingual flanges. So I would prefer to take the support of the lingual flanges during the healing phase, at least. So that is what my take would be.
Also, I think it would be a challenge if you're using your protocol where you're incorporating a metal reinforcement. It
Yeah, yeah,
becomes
yeah, yeah, yeah,
difficult to do
yeah.
something like that. Okay, one more question from Dr. Rijuta, who's asking, how do you manage the sleeve placement when the soft tissue thickness expected may be more?
Okay, so this is a very nice question. And to answer this, there are, now suppose if I am using, like there are 2 systems that I use mainly. One is Bredent and one is from BNB. It's an Italian company. So what they have in the guided part is they have implant planning. In the implant planning software only, you can choose whether you want to use a implant mount of a 2 mm collar height, 4 mm collar height, or a 6 mm collar, like according to tissue height. So they have different sleeves. So suppose if I have to place an implant of 10 mm, I will drill 12, but place a 10 mm with a +2 collar height. So they take care of that collar height. But in maybe Brilliant or any other system that I know, this option is not available. So at the most, what we can do is we can have the sleeve, cut it down from the bottom so that it adapts to the tissue if we are going flapless. So it will increase the chances of drill deviation. And if not, then you have to make sure that you open small flap in the areas where the sleeve is going to enter the tissue and not touch the bone. So when you match your data, you have to be very sure that this is the soft tissue level, this is the bone level, this is how my sleeve is gonna be. And I have to either cut it or open that flap in that area. But in systems like BNB, where they have an adapter to increase the tissue height by 2 or 4, that's a very good option.
Yeah, I would say think so. Yeah. Also, sometimes in very narrow mesiodistal spaces, the sleeves becomes a problem.
Yeah, it becomes a problem, then you go sleeveless.
Okay. One more question in terms of we saw some cases where you did a staged approach. How do you decide whether to go in the stage 2 with incision or then with a punch?
Punch, I'm not a big fan of in a stage 2. It will lose whatever volume of tissue I have gained by whatever things I've done. So I would always go with an incision and try and increase whatever volume I can still with a roll and pedicle. So I'm not a big fan of punch in the second stage.
Okay. And frenectomy before or after?
Both. Even if I do in the first one, it regrows in somehow the other way. So
Because tissue
whichever
closure is
way I
always a
can.
challenge, and frenectomy is one factor that needs to be
Yeah,
factored in always. Yeah. So.
yeah. So whenever I have done first time, I have to do it again some way or the other because some or the other frenum is still attached. So yeah, whenever, how much ever we can.
Okay, I think that brings us to any more questions, you can put it up, or then we bring this session to an end. And I think it's been a fantastic run through, right from all your digital as well as the analog cases and how you've handled each one of them. Thank you very much, Hemal, once again, and looking
Thank you.
forward to some more inputs from you. By the
Yes,
way, Hemal is also the editor for our Digital Dental Times, and we invite publications for the next issue that is coming up at the Congress itself. So please pass the word around to your friends and see if you can contribute your cases, your experiences, your research, which we can publish. Thank you very much once again, and
thank you. Thank
see you
you.
later.
Thanks for the opportunity, Dr. Bhusan. Yeah.
Thanks, Nim.